So what to do next? So if you've done all this really well, you've squirreled yourself away for 30 minutes in a quiet room and reassured them, and you've had this perfect conversation about what's happened, don't panic about what happens next, because there are heaps of experts out there and you absolutely do not need to know all of this stuff. Okay, we're blessed now with Google and everything else, so there are all sorts of ways you can get information, and one is the just old-fashioned pick up the phone and ring your sexual assault service. The health pathway for this stuff is amazing. Claire was one of the authors, or the author maybe, of the sexual assault pathway, and it is honestly the most amazing resource, and we use it the whole time in student health. So our nurses, if they get a disclosure, just go down the pathway if I'm not there and they can't pop in and ask me. In terms of medical support, SART stands for Sexual Assault Assessment and Treatment Service. There are, I think, 17 different SART services around the country, so there will be one near you or where you work. And again, think of inviting them to your practice for a CME evening. Think of getting your PHO to get them over and talk about what they do and how to refer to them, and put faces to their names, because it's really nice just to have that connection actually. Know who your specialist support agency is. Think about Safe to Talk. I'll show you the slide for that in a minute, but that's a really amazing platform now that people in the public can use to access services. You can get the police involved if you need to, and the police will be really happy to give you advice on the phone as well. And ACC and how to use their website to refer people if they are looking for a counselling resource. In terms of where you go and what you do next, really the only things you need to think about are the age of the patient in terms of which service you're going to ring and whether or not you need to do an Arama Tamariki notification, and the time frame since the alleged assault. So if this happened 3 years ago, you probably don't need to ring the sexual assault service right there and then. You can if you want to, and it's the middle of the day or something, but you know, it's not urgent. Whereas if this is a sexual assault that they're telling you has happened in the last week or so, then actually that stuff is really timely in terms of the doctor being able to look for injuries, provide STI prophylaxis, get some forensic type of evidence. So understanding the time frame and knowing about it is important, and on the sexual assault pathway that will sit there as well, some information about that. There's your 3D health pathway, and it's really, really useful. It talks about, you know, children and young people, and if the assault was over 4 weeks ago, so looking at it from the historical point of view. I won't go through the 3D pathway anymore. Safe to Talk, has anyone used or been on this website yet? This is fantastic. So it was launched initially in Canterbury in April and then nationwide in about July. And it's a sort of cross-government initiative, and it's actually the first time there has been a unified kind of nationwide multi sort of input way that patients or members of the public can access a whole lot of different ways of getting support. So you can text or e-chat or web chat or pick up the phone and get a trained support worker 24/7 who can advise you, talk to you, and then point you in the right direction of what else you need. So they can triage into our service, they can triage into counselling, they can suggest the mental health services or other resources that are needed. And it's actually really fantastic, and they have been swamped since they started. I asked them the other day, and they have had hundreds of calls per month since they went nationwide, which is fantastic. So I think it's now quite a visible platform for people to be using. And actually offenders can use this. There's a bit where you can say, I'm worried, I'm at risk of, you know, committing an offence with somebody, and they will put them in the right direction as well, which is great. Because I think you can text and web chat and stuff, it seems really accessible for young people. I've had lots of young people that have used this, and there's really good resources. I would recommend you just go and have a look on the website, because there's sections on things like dispelling myths around sexual harm, and, you know, was this sexual harm? What happens in my culture? And there's whole different sections that are actually really interesting, just information for people to have as well. And the people I know that have accessed that have been doing it often for family members or loved ones, actually.
Where is it set up by, sorry, or
MSD kind of hold it, but there was a whole lot of consultation across government, really. So they hold it, and I think it's the home care medical people that provide the support workers who had good training, actually, and they do seem to be doing a really good job. SARTS-Link is our particular baby from MedSac. So we developed a couple of years ago now this network called SARTS-Link that really its primary purpose is to connect the clinicians working in sexual assault services. So we've got 17 or 18 services around the country. Often people won't have a really high caseload. They may be working in relative isolation. There may only be 2 or 3 doctors in their area doing this work. So it's really hard for people to stay connected both to each other, other people doing this work, but actually also to the best and latest advice and resources and the ways that they should be doing things. So we've got incredible kind of best practice guidelines sitting on this network, and we've also got ways that people can ask. We've got an expert advice service that sits there, so if you're working in Invercargill and something crops up and you don't know how to deal with it, you can get an expert from one of the other centres to reply to you. There's lots of links on there, so there's links to health pathways, there's links to the ACC website, there's links to these police short films, and I won't play these now, but I think it was about a year, I think it was last April actually, the police funded, there's a series of about 7 short films, and they're only about 4 minutes long each, and they go through every step of the process. So if you're a patient and you have disclosed, it goes through, this is me at the police station, what's this bit going to look like? This is me going to the crisis support worker, how is this going to be? This is me going to the medical person. I did the medical examination video for them, and I look absolutely shattered because we finished at about 1 a.m, so it's a very realistic view of what I look like if you come and see me in the middle of the night. But they're actually really useful if people are kind of going, I'm not really sure if I want to do this, and you can show them because they look really non-threatening and they're very realistic. And they're currently doing one around the court process, so that will be up there soon, around what it's like if you go to court. And they're also in the process of developing one for children. So actually that would be much more child-friendly and appropriate if there's a really young person who's kind of wanting to know what's happening. And I think it's quite good to have a visual image rather than someone just telling you. So they're really useful to have, and they seem to be being used a lot by the crisis support workers when they're trying to explain what's going to happen next, and they can show them that. So I'll show you how SATSLink looks. So anyone can access this public page. So if you've got this link, keep it on your desktop, and if someone comes in, this is all you will be able to see, unless you're a member of MedSac. But you can go into, for example, Wellington, and it will bring up the sexual assault service, how to access them, what hours of the day you use which number, because at night you have to go through our support agency rather than ring the clinic direct. It will tell you who the local support agencies are and how to contact the local police. So it's a really useful resource, because what we often find is, if I'm seeing someone at student health who's had a recent sexual assault, their follow-up will be when they're actually going on holiday to Nelson, or somewhere else around the country. They're a backpacker and they're moving through town, so knowing actually, rather than saying to them, I'm sure there's somewhere down in, Nelson that you can go to, actually saying, hang on, I'll get you those details and we'll ring them right now and make the appointment for you, is really helpful. So check that out as well at some point. So if you are talking to someone about referring them to a sexual assault service, it's really good if you have a rough idea of what is going to happen to them when they get there, so that you can just explain it to them. And as I said before, it's actually really non-threatening. I think people imagine it's going to feel very sciencey and scary and be a sort of police process, and it's not at all. In general, there'll be a doctor and a nurse. There'll often be a support worker, depending which service you're in, as to whether they have access to that or not. And the primary and most important thing you need to tell people again and again and again is it really is just about their medical care. The rest of it is secondary. It's around finding them the right supports, making sure they haven't been injured, trying to prevent STIs, trying to prevent pregnancy, teeing them up with, counselling if that's what they need, giving them some night sedation if they're absolutely exhausted and traumatised. It's around that kind of stuff. Yes, there is a forensic element to what we do if the patient chooses that, but actually the therapeutic stuff is why we would like to see everyone who's been acutely sexually assaulted, actually, because they should get the best care available in that situation, just as you would refer for anything else if you were seeing something. In terms of the forensic stuff, partly that's around patient choice. People can opt into a forensic or opt out, depending what they want to do. But it does also depend a little bit on the time frame, because really, outside a week to 9 days, in terms of strict forensic evidence, there's going to be very little that we will find. So often we won't do them beyond that time period, which doesn't mean that we won't see someone. We will still do medical care, we can still document injuries if there happens to be anything still around, but in terms of looking for DNA to try and find an alleged offender, that time frame is probably passed by then. So if you're seeing someone within a week or 9 days, absolutely think about this, and pick up the phone and ring the service and say, look, it's 7 days now, this is roughly what happened to them. Do you think it's worth them coming into you for a forensic examination? The other thing that we offer is what we call a just-in-case forensic, which is a really fantastic option that we now have that a few years ago wasn't really so much of a possibility. And it's when people just have not decided what they want to do. So they don't know whether or not they want to involve the police. They know that they might, but they don't know, whether they do or not. And they're worried that by involving the police at that moment in time, they're not going to be able to extract themselves from that process, and the ball will keep on rolling. So they come and they get a forensic examination, and then the evidence is captured in time. We've got those samples there. That DNA won't decay. That's going to be there for years and years and years. That case is then stored anonymously for up to 6 months, and over that 6 months, we will contact them and they can contact us, and we will say, look, have you thought any more about this? Is this something you want us to contact the police about and you do want to proceed? And at that stage, if they do, they will sign a consent form and the kit will be released and the police will meet with them. Now, of those, we are now doing a massive number of those. A lot in our service, and I actually think that it's a great option. I can totally understand why people don't want to make a decision at the time. So giving them a chance to go home, talk to their loved ones, get some advice from other people is a really, really great thing. And of the ones that we're doing, I think around half in our service over the last year have gone on to proceed with the police. So that's kind of a win for the police in terms of those are often people that would have said no if they had to decide on the night.
Do they do them with kids, or is it mandatory reporting? Under 15?
Yeah, no, they don't do them for children because of that.
Yes, yeah. So we're seeing people 15 and over, 14 and over, sorry. And so regardless of whether anyone's getting a forensic or just what we call a health and safety examination, for anyone, these are the things we'd be doing. So a physical examination, treating any injuries, offering STI and pregnancy prophylaxis, and offering psychological support. And we also can do follow-up. Now, not everyone will take that up, but we are funded to provide follow-up if people wish to come in, and quite often that can be a really useful time actually to assess the psychological side of things. Actually, how have things gone for you at work now that you're back there, and now that you're back with your family, what's happening for you? In the future, we hope, we're talking to the funders about GPs or GP practice nurses being able to do follow-up, and that the funding actually that we get currently to do follow-up could be transferred to primary care so that you could do this in your setting. Now, that's not happening now, so if you are following people up, which sometimes people choose, unfortunately that means they're going to have to fund it themselves. But in the future it would be lovely if that was actually an option and the funding could follow the patient. So watch this space on that one. In terms of timeframes, you don't need to know particularly about this, but this is kind of how long roughly sperm hangs around for. But we always explain that even if they're coming to see us really early on, it doesn't mean we're going to find anything, and that depends on what's happened. If there's been very little contact, he wore a condom, for example, there wasn't any ejaculation, that's going to make it much less likely. If they have showered 3 times, changed 3 sets of clothing and really scrubbed because they're feeling really awful, again, less likely that we're going to see something. So we're really careful not to kind of promise things. The other option is that depending on the police's decision about the case, the kit won't always be analysed either. So we will do these cases, and actually, if there is not enough for the case to proceed beyond that, it isn't always analysed, and the patient doesn't certainly often get any answers, unfortunately. In terms of what you need to know, you don't need to know all of these bits and pieces, but just enough to triage and manage it effectively. So it is probably helpful if you know roughly the time frame, the age, and maybe a little bit about what happened, but you do not need all the details. And actually it's better if you don't ask all of those, because we will have to ask all of that. And these are the reasons why people might want to go forward with the just in case rather than anything else. Often they're exhausted, they're acutely stressed, they've not had good support people around them to give them advice, and they want to go home and speak to their mum or their partner or their best friend about this. And so it is really useful to be able to offer them this. And at present, we've got 6 months before they decide. That may change because we're running out of storage space in New Zealand for all these kits, unfortunately. But at present, it's 6 months. So what we actually do during a forensic examination, we can whip through this because it's not going to be terribly interesting, but everyone gets a kit that's assigned to them, and that's a unique kit just for them, and all the samples get sealed back inside that kit at the end with a copy of that booklet. This booklet is quite a big detailed document in triplicate, so a copy goes in the kit which goes to the ESR science lab to be analysed, a copy stays within the sexual assault service, and a copy goes to the police if they are reporting to the police. First thing we do is documentation. So we try and document just the history that is needed to guide our examination. So we don't need to know the names of the 12 people that they were out drinking with, but we might need to know, that they were out drinking and then they were in a flat when the sexual assault happened. You know, we might need that detail, but the detail around it, actually, we don't need to know, and it's much better that we don't record that in this particular booklet. We always talk about alleged events, as Claire said. You know, we don't want to be seen as being biased, so we would quote in quotation marks or write about alleged events, and we would always try and say who told us what. So was this history all from the victim that's in front of us, or actually is this information that the police have got from a load of other people, and we need to put that in there. Talk about the limitations to our examination. So it's sometimes really difficult to do an examination. Someone might be really distressed, there might be some blood there, they might not be in a situation where they want you doing a genital examination. So we talk about that and describe what you see. So exactly the same as Claire said, if you were doing this, you don't need to know the name of every type of injury, just talk about what you see. And actually this illustrates Claire's laceration versus incision. This is an incision with a clean margin, that is a laceration. So if you'd smash the tomato like that rather than cut it, you'd see a really different pattern of injury. And we use lots and lots of diagrams. So that is an example of a genital diagram that we might have. If there were injuries, we would document them on there, and then when we go to court, it's a really useful way of showing jury members, different parts of the body and trying to explain what the injuries might mean. Medical considerations always take priority over a forensic. So if you see someone, and this might be an example of one of the things that we would do on a face diagram if there'd been lots of injuries to the face, actually dealing with these injuries and making sure there's no brain injury, there's no concussion, there's no sequelae from the strangulation is far more important than doing these diagrams and interpreting them. A lot of these cases will not end up in court, so actually our therapeutic care is always the most important thing. When we're looking at genital injuries, as I mentioned before, only about a third have genital injuries. And we also know that there have been studies looking at consensual sex and that there are injuries in consensual sex as well. So even if we see genital injuries, it doesn't necessarily mean that there was non-consensual sex or sexual assault. There is a higher injury rate in anal assault and a higher injury rate in postmenopausal women for the reasons we've talked about, and a higher rate in prepubertal children as well. Now, the reason why there are no injuries, and I should have bought a scrunchie to show you, but is, that the genital tissues are super stretchy, as you all know. They're made for childbirth, so, after puberty and before the menopause, everything's actually really robust down there. So you can have very forceful sex without any injury at all. It may have been that actually there wasn't penetration, that the sexual assault involved touching over the clothes or attempted penetration or something else. Or, as is often the case, we might see people days after a sexual assault, and the skin down, or the tissues down there are similar to kind of, inside your mouth, so they heal really quickly, much more quickly than normal skin if you're injured on your arm. So if someone doesn't come in for 2 or 3 days, it's impossible for us to say what we might have seen immediately after, because it's all looking completely back to normal down there. The other option is that, perhaps what they're telling us didn't actually happen. These are diagrams as well that I would always take to court to explain to people, if a defence lawyer might say, for example, well, couldn't they have got that injury falling down the stairs or slipping while they were doing the washing up or something? And you say, well, not really, because in its resting state, this is, we're covered up down there in the resting state, and this is when things are exposed and legs are spread during the examination. So it's useful, I think we use it as a bit of an education opportunity for the judge and the juries when we go to court, just to give them an understanding of what women look like. So hymens and virginity, and this is, there's a really good talk which I meant to link to on here, but Cathy Lowe's, we could maybe send it out later, she's done an amazing talk about virginity that every young person should see, because I really think if you ask questions about people's understanding of hymens and virginity, the myths out there still are astounding, and people really genuinely believe it's something that covers the vagina and it's perforated at the time of first sex, and there's got to be blood and there's got to be pain, and if that doesn't happen, then how could I have been sexually assaulted because I hadn't had sex before and there wasn't any of that stuff going on? Of course it's not. It's a stretchy thing outside, the entrance to the vagina that can absolutely distend as needed. I think one thing from the point of view of you when you're seeing people, and for me when I see these people as well, is actually telling them that they're still a virgin, and that can be a really, really powerful thing. If this was their first sexual contact and someone has forced this, they have not lost their virginity. And actually for lots and lots of people that is incredibly powerful to know. You can't have that taken from you. You choose to give that. at the right time for you. And that's a really great thing for them to take away. So again, something I would really encourage you to actively say. Don't wait for them to ask you. And also, around the, is my hymen going to look the same? Is it intact? Will anybody ever know? No one's ever going to know. No one's ever going to look down there years later and go, oh my God, were you sexually assaulted 10 years ago? I can tell. But a lot of people will really, really worry about that. And I've seen a lot of students who, were in the situation that something happened when they were 15 or 16 and they don't disclose or understand it till they come to university. And they have never had sexual contact since, partly out of a fear that someone will know and ask them actually when they have contact. So again, pointing that out to them, it's not the case. Nobody will ever know about this. And understanding that penetrative sexual assault doesn't usually cause trauma. So it doesn't mean that it didn't happen. Just because they haven't got an injury, they will still be believed.
Can I just interrupt?
Yeah, sure.
About the hymen. One of the really useful things for young people is to say, what do you understand about your hymen or whatever? And some people say, oh, yes, it's this membrane that covers up the entrance to your vagina or whatever. And I was sort of saying, oh, well, that's what people used to think, but they're quite wrong, because if you think about it, when you have your period each month, how does the blood get out?
Yeah.
And they kind of say, oh, it says there's a hole there. There's been a hole there since you were born. And that's very reassuring for a lot of them, okay? Because they can understand that. It comes out each month, so there must be a way out.
And in Cathy Lowe's talk that she does, it's really worth watching, but she talks about, she's done a whole lot of kind of Google searching about, virginity myths and hymens and all that kind of thing. And she talks about one where in some cultures it's so important to have bleeding when you get married after the first lot of intercourse, otherwise you're shamed because, you weren't a virgin, clearly, that they sell this pack that has a little kind of vial of red stuff and you tape it next to your vagina. And after you've had sex, you pop it and run out with the bed sheets and go, ta-da, here we go. Which is really sad, but the thing I find amusing is that they only come in packs of 25. So actually, 25 times you can be a virgin for $12.99 plus postage and packaging, which is extraordinary. So it's worth Googling her talk, she's great. So in terms of what we do forensically, we do urine for toxicology, and ideally the sooner we see people for that better. Lots and lots of drugs that we suspect may be used in sexual assault settings, we don't know because we often can't prove, because even within a few hours some of them will have gone from the system. So the sooner we see people the better in terms of that. We do swabs, which are looking for all sorts of things, but often looking for foreign DNA. So for example, if there had been oral penetration with a penis or ejaculation, we might find DNA or semen in the mouth. So we will swab kind of any part of the body where we think there may be saliva or skin DNA or semen or something like that from an alleged offender, in the hope that that will be able to identify them. Nail clippings, which are often looking, or nail swabs, often looking either if someone, as Claire was saying, in a strangulation, you might try and get their hands off and scratch them, there's been a struggle, or for trace matter, which can be little bits of, gravel or dirt or fibres from the back of a taxi or whatever, depending where the assault happened, and they may be underneath the nail. And ESR can do extraordinary things with these samples. We have very, very clever scientists who can do things with this stuff. And their advice to me once was never let your kids get in the back of a minicab that has had a bit of the upholstery changed, because something unpleasant has probably happened there. And the rest of the upholstery is in their lab. Yeah, I know. Hair sampling. There's a few reasons we get hair, but one of which is to match up with hairs at the scene. So ESR can kind of sometimes quite accurately match up hair that might be found in the bed at somebody's flat with hair that we've taken from a patient at the time. The other thing we can do with hair is further down the track, at over a month, ESR can track a range of drugs through hair segment growth. So if we haven't seen someone within a week or so, and we actually haven't got forensic samples, but we do see them at a month, and there was a suspicion that there was drug involvement, we can get hair samples that will look for toxicology as well, and they can date that back reasonably accurately, actually, for a certain range of drugs. So if you're looking at STI prophylaxis, and again, this will be done by the Sexual Assault Service, but if for any reason someone doesn't want to come in and you're dealing with this is the standard protocol that we would tend to do. So we might talk about giving azithromycin to cover chlamydia, and it covers a little bit of gono. Might do metronidazole depending on that. Hepatitis B, if they're uncertain of their status, we might give the first vaccine at the time. If they come to you after a sexual assault, hepatitis B is funded after sexual assault. So if they're not immune, they can have that vaccination then, if they need to. Sometimes as well, we just do bloods for serology and decide later, but a lot of our patients don't come back for follow-up. So if we're worried, we might do it at the time. I give out a lot of clomazole actually. We have a big supply in our clinic in the drawer, and I do often give it to people because there's a lot of tenderness afterwards, and I think they're really likely to go on and get thrush just because of kind of the friction and stuff, and it just seems to make it a lot more comfortable. And if you're worried about a risk of gonorrhea, obviously KEF IM is the thing to use. We talk about HIV PEP. I would say, in my experience, Claire, I don't know about yours, I very, very rarely actually prescribe it, because very rarely does it meet the threshold where we would be concerned about that. And in the odd occasion where it does, often the patients will choose not to anyway, actually. But it's a really important conversation to have, because you never know what people's fears are, you know, until you ask, actually. But one of the biggest fears sometimes, and especially seems to be for male victims, is around HIV. You know, what is my risk of HIV after this? So just going through the algorithms of actually, this is your risk. This is your risk after one episode of unprotected anal intercourse with a stranger male in New Zealand. You know, this is the risk is 1 in whatever it is. Can be all they need to know. And then they walk out feeling happy, because they probably think their risk is 1 in 1, you know. And it's great to know that it's not. If they do need PEP, it needs to be within 72 hours of exposure, and every area will have their own protocol for this. Here we do it through the infectious diseases team, but it's worth knowing who your local people are, you know, if someone needs to access that after hours. And these, you can get these algorithms online, but they're really helpful to have conversations with people actually in terms of risk. Always think about safety. If they are under 17, if they're not already involved, and if the police aren't going to see them and do the notification, you need to think about oranga tamariki. If they need mental health support, obviously use the local agencies just as you normally would. And if it's an intimate partner violence setting or a partner and you're concerned about their safety, contact Women's Refuge. And always, always check, you know, that when someone is leaving your clinic or leaving our service, you're not sending them back to a situation that is unsafe. And that may be because the perpetrator is at home with them still, or actually because there's going to be that retribution from the family. You should not have been at that party, that's why this happened, you know, and then they get beaten up by someone else on the same night that this has happened to them already. So ACC support sessions and counselling. Someone mentioned to me yesterday, because I work at Student Health, our service is free, so I do not tend to do ACC 45 because our patients don't get charged for coming in. But if you are in a general practice setting and you are charging, an ACC can fund some of that for the patient, then obviously it's really worth doing. So you do an ACC 45, you can send it electronically, and then it will be siphoned off and go through to sensitive claims department. Now obviously you need to have an injury, so it's either physical injury or mental injury. And on their website, actually, there's a list of codes that you can use. So if you go to findsupport.co.nz, which is that website there, that's the sensitive claims bit of ACC's website. And I might have got it on here, actually. No, I haven't. On there is a way that patients can find a provider as well. So they can put in the region they're in, whether there's a specific gender of therapist they'd like, or it doesn't matter, and it will bring up the list of ACC counsellors in their area. Now, unfortunately, in my experience, what it doesn't bring up is any availability. So it says there's 15 providers in your area, and then patients will come back in and say, oh my God, I rang all 15, it was terrible. By the end I was in tears because no one would even put me on the waiting list, which is absolutely awful. Now, ACC are really aware of this, and they are, you know, there's a big project happening there at the moment to try and see if there are different ways they can make the resources meet the demand, but it is difficult. So trying to explore locally what your other options are in terms of safe places that these patients can go for support until they can get into a counsellor is really important. And that might be help or rape crisis. You know, our help service, for example, Jackie will tell you shortly, but you know, they will see people for support sessions. They've got drop-in clinics, you know, so it's not ACC sensitive claims counselling, but it's someone that can support and advise them until that space comes available. So really important to know who your options are in that space. And I think we often end up supporting them, but probably don't, you know, it's probably not our skill set and we don't do it terribly well. You may see people who have this kind of presentation, you know, drug assisted or alcohol assisted or drug facilitated, there's lots of different words for this. And it's a really common presentation for us, which is where people have very little memory of what's happened, but think that they have been sexually assaulted. We know that alcohol is the most common drug, and that is either they have voluntarily drunk a whole lot more than they imagined they had and don't know the impact that that's going to have on them. They may have drunk a whole lot of alcohol and haven't realised the combination with their own meds that they're on or recreational drugs that they've taken and the effect that that's going to have. or their drink has been spiked with alcohol, which sounds ridiculous, but the police have told me lots of times of occasions where they have heard of, they've been asked if they want a drink, and the guy will say, right, I want a triple put in there for her, and go back 3 or 4 times, and she's had 10 units in a really short space of time, having no idea that that's what she's been given. So alcohol is really common. We know that other drugs are used as well, but as I said before, it is really hard to detect them. So we often don't pick them up or get proof of that. How they will often present to us is with only partial recall or very little recall of what's happened, and lots of unexplained symptoms. So waking up feeling really different than a normal hangover for them. So maybe profusely vomiting, terrible headache that lasts for a couple of days, dizziness, nystagmus, unsteadiness, all those bits and pieces. And we can do drug testing. And people can actually get drug testing privately through us if they choose to do it. So if they don't want to go to the police, but they do want some information about that, they can pay, and it's not massively expensive actually. So sometimes people go for that option just in terms of wanting to understand what's happened. And if someone says they absolutely do not want to come into us, what do? You do basically all the things we've talked about. So try and provide the best medical and psychological support that you can. Think about STI screening and prophylaxis. Think about pregnancy prophylaxis, and remember that even after sexual assault, gold standard emergency contraception is an IUD, actually not Postanor, which seems bizarre in the setting of sexual assault, but that's still the situation. So if you know how to access that in your area, that's a great thing. Document it as much as you can, and if you can access some diagrams, I find them really, really helpful in terms of if there's lots of bruises and abrasions and that kind of thing, actually drawing on where they are. Use your specialist sexual assault support workers. You may find that they'll actually come to your surgery if you've got someone. They'll do that at Student Health for us, which is fantastically helpful. And ACC, you may want to make the claim, and then it's cheaper for them to come back and follow up with you. And police, people can sit down with the police anonymously, and I'll often organise this for people. I'll ring our local detective and say, they don't want to report, I'm not going to give you their details, but they want to sit down and hear about your process from you. And, then they can decide yes or no if it's something they want to go ahead with. But you can use the police like that. The police will also, they may or may not tell you this later on, they will also sometimes go and have a discussion with an alleged offender and say, this stage nothing's happening, but we kind of know that there's been something alleged, and we may be watching you a little bit. And so, talking to the police and getting a relationship with them is a really, really good idea. Discuss if they want follow-up and who they want it to be with. They may actually feel more comfortable going to a youth one-stop shop or going to another provider and just coming to you for their normal GP care. That's absolutely fine. And ensure that you tell them about the option of a just in case. Reports. Claire has already been through all this, so I won't do it again, but get advice. You can talk to your local SATS clinician, you can ring MedSac if you're not sure, you can talk to your MPS. There are people who will do reports and give you advice about this, who are really experienced, so don't go it alone. You don't need to. And MedSac, if anyone is interested in joining MedSac or doing this work, we can highly recommend it. It's actually really, really, really rewarding work, truly. I love it, and probably it's the one place in my work life where I feel like we actually make a real difference. Actually, if you do this bit well when someone's been through something really traumatic, at the end there are hugs, there are why-arters, there's tears, there's love, there's, and they all walk out saying, I'm really pleased I came. And I don't get that in my normal clinic, ever, actually, really. But it is great, and it's a real privilege, actually, to be a part of that person's journey. So this is our organisation. If you want any more information about it, let us know. And I think that is us. And my email is at the bottom. And I actually put my phone number thinking, if anyone's ever stuck, I totally don't mind being rung. So seriously, maybe not 4 a.m, but any other time. Really, really happy.